Hello, everyone. Are we ready to get started? Okay. All right. So today's research plenary session is Overcoming Stigma in Our World. And we have several guest panelists with us today who are specialists in the area. I'm Dr. Settles Reeves, and I'll be the moderator today. So let me introduce our speakers. We have Dr. Shaw Dalasaga, PhD, Professor of Humanities from Penn State University, Harrisburg, Pennsylvania. We have Dorothy Adriana Andrea, please forgive me if I mispronounce her name, MD, PhD, Associate Professor, Department of Dermatology, the Division of Allergy and Immunology at the University of Utah. We have Dr. Ovgul Kanyak, Assistant Professor of Psychology, Social Sciences, and Psychology Director also at Penn State University Center for Addiction Outreach and Research. We have Dr. Brenda Curtis, PhD, MPH, Chief Technology and Translational Research Unit, National Institutes of Health and Drug Abuse. And we'll be discussing the stigmatizing language of substance use. So our first speaker, Dr. Dalasoga, I guess I will turn it over to our first speaker and let her do a much better job at doing a brief interview.
I answer to any facsimile of my name.
How are you? How are you?
I'm great, thank you. And Dr. Andrea is also presenting with me.
All right, thank you.
So we are co-presenters.
I am starting to share sound. I'm starting to share my screen. Okay. So we are going to talk on patient prejudice toward providers, which we coined PPTP. And we will jump right into our first video.
Go in and check on Mrs. Marks, please.
Hello, this is my first night.
You'll be fine. Just check her vitals and see how she's doing. I'll be in as soon as I can.
Any special tips? I know she was here a month ago and a month before that for the same condition.
We keep suggesting that.
Please unmute your microphone so we can hear the video. Thank you. You have to unmute your microphone, Ms. Adriana.
Hello, this is my first night here.
You'll be fine. Just check her vitals and see how she's doing. I'll be in as soon as I can.
Any special tips? I know she was here a month ago and a month before that for the same condition.
We keep suggesting that, but apparently she prefers to get her health care in the ED. I think she has anxiety. Her mother suffered from angina, and now Mrs. Marks is convinced that there's something wrong with her. She's pretty much refused all of our follow-up. And basically there's nothing we can do. It's just a lot of hand holding. So don't worry, you'll be fine.
Okay, I'll do my best.
Come in.
Hi, Mrs. Marks. I'm Kayla. I'm a medical student. Your doctor told me to come take a look at you, if that's all right.
I guess so.
All right, so I have my clipboard here so I can check your vital signs and write them down. Wait a minute, I forgot my stethoscope. I'll be right back.
I don't know. Where do you think that student is from?
Hard to tell. Hard to tell, isn't it?
The last time I was here, that nice doctor from Philadelphia took care of me.
Yeah, right. We need to look into this.
Okay.
Can't believe I left this lying around. Definitely needed to take a good listen to your heart.
We were talking while you were out of the room, and we would prefer an American doctor.
No offense, but I don't want some foreigner examining my wife.
So it looks like maybe we're having some technical difficulties. So maybe I will jump in while Dr. Andrea fiddles with the video. I'm wondering if, and you can do this by chatting or by direct feedback, what kinds of stigma did you see in that video? Somebody said it wasn't very nice. So what were the stigmas that that you witnessed in that scenario? It was sad, there was discrimination, xenophobia. Age, possibly, good one, yeah. One we don't always think of. Okay, toward the doctor, kind of ignorance, yep. So these are, yes, thanks for all that feedback. These are the kinds of experiences that we would fall under the rubric of PPTP, and that is the topic of what we'll be talking about.
So, yes, I'm sorry about the video. This was the video that we could watch. That is the extent of the video we could watch. And this is a daily reality for many doctors and nurses. This is not a singular event, but is something that happens every day. And I'll just go into some statistics. 95% of all medical students, and that is, you've said age, experience some form of harassment, discrimination, which contributes to an uncomfortable learning experience, learning environment, and impaired student performance. And research has shown that medical students who frequently experience harassment are less likely to complete assignments, to complete their training, and have more emotional problems like depression and anxiety compared to their non-harassed counterparts. This is significantly more pronounced in minoritized trainees. So this is not just a little bit of a difference, it is a very big difference. For example, minoritized residents are 30% more likely to withdraw from residency, the training after medical school, than their white counterparts, and 8 times more likely to take extended leaves of absence. And the research we started is I'm from Germany originally. I trained in a very diverse environment in New York City, in Queens, where we were all international physicians. And I witnessed a lot of stigma, a lot of bias from patients directed to my colleagues, and also to me sometimes, but very often I witnessed it in the training.
Someone in the chat also mentioned that the student had left her equipment, so that may have promoted some bias as well.
Yeah, that is a very good point. The need to overperform. So be better than, because another student might not have been discriminated.
Am I taking over, Dr.
Yes, you're
Andre?
taking over now.
Okay, all right. So really, we don't have a lot of research on this topic. We have a little bit of research on stigmatism within the healthcare professions, but a pivotal case study really made us start looking at it back in 2016. And what this case study found was, Adriana, you want to pop that up?
Yes.
It was about a 77-year-old white man seen in the ER of an urban hospital. And when a Black physician entered, the patient said, "I don't want to be cared for by a blank doctor." And it's almost identical to the scenario that we shared with you. So there are a lot of ethical and legal issues resulting from this stigma. And it doesn't even, this has like application. It could be a teacher that walks in the room and gets this treatment. It could be the first female engineer who walks in. It could be a variety of professions. So we're just looking at medicine, but we recognize that this is a broader problem than just healthcare. Do you want to go on to the next one, since
Yes.
we're running short, I guess?
And based on these experiences and the awareness that this is something that happens in the healthcare system daily, we launched a study doing in-depth interviews with residents, and we started with residents and fellows to interview them about their experiences with bias and stigma from patients and their families directed towards them. And at this time, we have interviewed 11 residents, 19 physicians, and 5 nurses on their experiences. And we have about 1 hour long interviews with each. The results of these interviews, we are currently publishing the results of the interviews, and we use them to develop a patient prejudice towards provider survey. In May 2021, we launched a nationwide survey for nurses on stigma and bias, and we have close to 2,000 responses to date. And we do have a physician survey that will be launched in the near future. And Cheryl, this is.
Yeah, maybe, I'm not sure how much time to take. Dr. Settles.
We have about 5 more minutes.
Okay, maybe we should skip past this one then. And maybe later at the end when there's discussion, if anyone wants to share.
Yeah, so this was yours as well.
So in our study from these interviews, some of the examples of the most prominent themes that came out was that there was this continuum of offense. It might be something verbal, might be a body language, all the way up to people refusing to have a particular physician take care of them because of their background. There was also a difficulty in how you respond to this, because doctors have a moral obligation to do no harm. So when something happened, how do you respond meaningfully to the patient? It definitely showed an impact on the therapeutic relationship between the patient and the provider, as well as the team and the provider. And I think this would go across many disciplines. Basically, these experiences became a way for these providers to kind of accommodate into their professional identity and sort of identity. and take action for like proactive responses, or what kinds of things they would do in the future if the same thing happened. There was a lot of feeling like they needed to justify their role as a physician. And it was interesting because we're now looking more closely at the women, because there seem to be preferences for male providers over women, regardless of their status. And there was certainly a protectiveness towards the minoritized trainees that experienced this. I guess the attending sort of felt that they had learned to deal with it, but for students, it was a little different.
So we wanted to speak about the impact on education, because these situations arise in all areas of the healthcare system. And as we discussed before, trainees are especially vulnerable. And the fact that this trainee forgot her stethoscope might have placed her in a more vulnerable position because she is a trainee, but then triggered a whole other area of rejection. But in training medical students and training residents, we have noticed a lot of uncertainty, hesitancy, and concern about how to address and discuss these toxic encounters that may arise and hamper the education, but also affect the teamwork. And the big question is, why is it so difficult to talk about it? Why is it so? It is difficult to a point that training sessions might be avoided on this topic. And how do we frame, if we want to make sure that we talk about this, how do we frame it to reach the broadest possible audience, but avoid drifting into divisiveness, to avoid, so that we can speak about the problem at hand and not about other circumstances. So possible applications and approaches. The affected providers are often alone in these situations. They may be physically alone, or they may be psychologically alone. They may be the only minoritized trainee or physician in the room, and nobody else really is aware of what is going on, and that this comment was a microaggression or was an overt aggression against this physician or against this trainee. There is an acute need to increase the awareness and to support affected providers. So these film scenarios that we presented, one of those, they can be used for all education at all levels. For example, we did a Schwartz grant rounds on this, where we spoke about these issues. And we are hoping that ongoing research will lead to an increased awareness, to a culture change and a long-term change, because the idea is to create a culture of upstanding, to increase the awareness of not affected providers, to speak up and to support, and to make clear that this is not acceptable in this team, in healthcare in general. So we are at the 15-minute mark now, and I don't know. I think I will stop my share.
Are there any questions for this presentation from anyone in the audience, please?
I think we were going to do questions at the end.
Okay, all right, thank you. So we'll move on to our next speaker. I'll do Dr. Kainak. And please forgive me if I'm mispronouncing your name.
No problem, you're not alone. Hi, everyone. Thanks for having me. I'm thrilled to be part of this session. And my name is Dr. Urfka Kainak, and I'm an assistant professor at Penn State Harrisburg, as was mentioned, and the lab director for the Douglas W. Pollock Center for Addiction Outreach and Research. And today I'm going to talk about Life Unites Us, which is a statewide project addressing opioid use disorder. And before I do begin, I just want to mention my partners. The Pennsylvania Department of Drug and Alcohol Programs, who is also our funder, and the nonprofits, the Public Good Projects and Shatterproof. So Life Unites Us just started its second year in the state of Pennsylvania. And in Pennsylvania, nearly 13 people die of a drug-related overdose each day, and 82% of those deaths involve opioids. Almost half of the general public knows someone who is living with an opioid addiction, and despite having increased access to treatment via telemedicine, opioid-related deaths have skyrocketed during the pandemic. So when this project was being conceived, our team looked at what was actually driving the opioid epidemic. And as you can see from this list, 7 of the 9 drivers of the opioid epidemic are either partially or entirely driven by stigma. And stigma generates multiple barriers for people with an opioid use disorder to seek treatment, receive treatment, and stay in recovery. And unfortunately, people with OUD can progress on their path to recovery and still be faced with these barriers. And we also know that stigma related to addiction often overlaps and intensifies with other forms of stigma, discrimination, and bias, such as those related to race, class, gender, sexual orientation, occupation, and others. So I won't spend too much time on this slide because this is a stigma conference, and I know that we're all pretty well versed in stigma in many of its forms, but one of our nonprofit partners, Shatterproof, put together a white paper on stigma that looked really closely at success factors that enable change movements. And they identified 6 key success factors to address 4 types of stigma specific to addiction. And our campaign mainly focuses on changing public and self-stigma. But as we go into years 2 and 3, we are expanding our messaging around other types of stigma. And I will mention that one type of stigma that's really specific or can be specific to addiction is stigma against medications for OUD, and that's something that we're going to be focusing on more in years 2 and 3. So let me move on to campaign strategy and objectives. So the campaign is an evidence-based approach towards increasing knowledge and decreasing stigma around those living with OUD throughout Pennsylvania. And we do that through increasing knowledge about OUD and that recovery is possible with proper support, by improving attitudes towards those living with or who are in recovery from OUD, and then increasing self-efficacy to provide support among those who have a loved one with OUD. And we do that by, we're accomplishing these objectives through a variety of dissemination channels. So Life Unites Us, the campaign, actually features individuals sharing their stories of hope and resilience through a story library and through social media to the general public and across the Commonwealth. The campaign also uses influencers and targeted paid media to reach targeted audiences who may hold stigmatizing beliefs, to show them that there's more to an individual than OUD. And then finally, community-based outreach or community-based organization outreach and connection is really vital to the success of the campaign. And the campaign has partnered with CBOs across the state to encourage engagement with the campaign, which includes sharing testimonials and campaign content. And I'll talk a little bit more about the CBOs and their engagement on another slide. So we have key messages that target 2 audiences. Our primary audience is the general public who could hold stigmatizing views. And we're trying to help this audience to understand that recovery is probable, that reducing stigma makes recovery more likely, that addiction is a treatable medical condition, and that people with addiction are just like everyone else. They have lives and jobs and families. And our secondary audience is made up of those who live with OUD or in recovery, or are loved ones of someone living with OUD or recovery. And this is the community that is built in the organic social channels. And we're trying to help this audience to understand that storytelling can be really powerful, and that it can be used to help change the narrative about opioid addiction, that each and every story from across the state decreases the stigma surrounding addiction, and that together we have the power to end stigma of opioid addiction. And I do want to mention that as the campaign rolled out, we wanted to make sure that messages really resonated with and were inclusive of all communities. So we formed a community impact committee to incorporate feedback from individuals in recovery. And they continue to be a part of the campaign and the project. So here's just one example of a testimonial.
I wound up working as a paramedic after high school. That's what I went to school for, and I wound up doing that for about 15 years. And I wound up with a couple random work injuries. Wound up getting Percocets, Vicodins, things like that, and became more and more dependent. Going through withdrawal symptoms. So it's 4 years ago currently. That was the last time I had used opiates. I overdosed on my parents' living room floor at that time, and the paramedics that revived me were former coworkers. So I took some advice, and I got on Suboxone, and I was very much against it because it was very taboo at the time, but I was dying, and I needed to do something different. I needed to take that principle that they had taught me in AA and apply it here, and I did. It wasn't the miracle pill. It wasn't the cure. It was a tool. It was one tool. My life is amazing today. And I have a home, I have food in the refrigerator, I have clothes on my back, I have my kids in my life. I have a career where I work every single day to try to help people who struggle in the same way that I was. Because I believe that's one of the reasons that I was kept here, is to take all my experience and be as open, vulnerable, and transparent with the world as possible, because that's the only way things are going to change. The stigma surrounding this topic was certainly something that kept me suffering in silence for many years, and it's one of the things that almost killed me. When we hear about somebody overdosing for the third or fourth time, we think, man, can't they get their stuff together? That's stigma. That's stigma. Stigma just dehumanizes. Stigma is just another word for discrimination. It's a way to remove the humanity from people. We're really not all that different. We're all just human beings.
Okay, so that's just one of over 200 stories that have been shared. So this is some digital campaign metrics, some of our metrics through year one. And as I said, over 200 Pennsylvanians have shared their story of recovery, and we add more each week. In terms of social media, we've had 3.9 million impressions, 1.2 million video views, over 100,000 engagements, and over 1,800 followers across 4 platforms: Facebook, Twitter, Instagram, and YouTube. And then with influencers, we have 51 social media influencers that are involved with the campaign, which have brought in an additional 1.2 million impressions. So Life Unites Us utilizes a collective impact approach, which means that we're a group of actors from different sectors, and we're committed to a common agenda for solving addiction stigma. So we're doing that by using a structured form of collaboration. And an important piece of that involvement comes from the CBOs and their involvement, and they're really encouraged to partner with the campaign. So CBOs who do partner with the campaign, they have their logos featured on the Life Unites Us website. They get exclusive access to a curated testimonial library. They have access to ongoing campaign webinars and can contribute to topic ideas for future webinars. They also receive technical assistance for campaign involvement and activation, and they're encouraged to represent on the Community Impact Committee. And I also want to mention that each month we send all partners a batch of new videos that have not all been featured on social media for them to be able to disseminate through their channels based on the demographics of the populations they serve. And right now we have a little over 70 engaged partners across the Commonwealth. I just want to talk a little bit about some of the data collection that we're doing as part of the study. So as I mentioned, we're using an evidence-based mixed methods approach to the project. Started with an exhaustive literature review to better understand statistics specific to Pennsylvania, as well as previous research to inform campaign development. And before the campaign started, we conducted a baseline survey that included a total of 1,033 self-administered web surveys completed by adult Pennsylvanians between June and July of 2020. And the survey used a quota-based invitation system to produce a final data set that's representative of Pennsylvania's population by region and then separately by age, sex, combined categories. And some of the categories that we covered with these questions, we looked at general attitudes towards OUD, attitudes towards policy related to OUD, and then public stigma and self-stigma related to OUD. And the survey actually gets administered every 6 months throughout the campaign. We did the 6-month survey in February of 2021. And at that time, we also added some questions about campaign recognition, which I'll get to on the next slide. And we just finished up collection for the 12-month survey, and we'll have results for that in the next month. Along with the quantitative survey, we also conducted and continue to conduct one-on-one qualitative interviews with various groups within the addiction field. So we do about 20 interviews every 6 months. We're currently doing interviews with family members who have lost someone to addiction. Our next round of interviews is going to focus on people living in rural areas. So what have we found so far after 6 months? So at 6 months, we found that 40% of respondents had reported having a family member or close friend with opioid use disorder. 80% supported the use of treatment instead of criminal justice involvement for individuals who have not committed a felony. And half were willing to purchase or obtain naloxone, with 2/3 willing to provide naloxone to friends or family members of people with an opioid use disorder. In terms of the actual campaign engagement, 1/4 of Pennsylvanians were exposed to the Life Unites Us campaign during the first 6 months. And when we compared those who viewed the campaign to those who did not view the campaign viewers were more likely to say that prescription opioids can be a problem for anyone, that medication-assisted treatments are effective, and that they would be willing to purchase or obtain naloxone. They were also more likely to support harm reduction strategies. So things like safe injection sites, needle exchange programs, fentanyl test strips, and naloxone distribution. And so moving into years 2 and 3, we, based on feedback from DDAP and from community partners, we're going to be expanding the campaign messaging and focus to include stimulant and polysubstance use. We're also going to be expanding resources and engagement for the CBOs, including a workbook. And the workbook will really focus on helping to enhance the work that CBOs and RCOs are already doing to reduce stigma by helping to enhance the work or by helping to kind of fill in gaps and thereby increasing self-efficacy with implementing stigma reduction in a way that's going to work best for their communities. And then we're also working to expand diversity, equity, and inclusion efforts for the project. And this includes the testimonials and participation in the Community Impact Committee and also those qualitative interviews I talked about. Okay, thank you so much for listening. I'll be happy to answer questions at the end of the session, or if something comes up after the session, please don't hesitate to reach out. And I've also included the campaign social media handles if you're interested in following along. Thanks so much.
All right, thank you. Next, we have Dr. Brenda Curtis, again, Technology and Translational Research Unit at the National Institutes of Health, the stigmatizing language of substance use and recovery. Thank you, Dr. Curtis.
Well, thank you, everyone. What a great presentation. Can everyone hear me and see my slides? We're good, okay. So I'd like to start off, let me move forward. There we go. I'd like to start off with a quote from a paper that Dr. Volkov wrote, who's director of the National Institute on Drug Abuse. And she so eloquently put it in her 2020 New England Journal, where she said, while considerable progress has been made in recent decades in reducing the stigma associated with some psychiatric disorders such as depression, such change has been much slower in relation to substance use disorders. And in this article, she goes on to discuss the impact of stigma surrounding people who have a substance use disorder in the community. And one of the areas that I really focus on is our use of language and how language in treatment and language in recovery impacts people who are in treatment and outside in our communities. And, the first question people always ask is, why language? We have those phrases about sticks and stones may break my bones, but words will never hurt. I disagree. Words hurt immensely. So why study language? Well, how we talk about a disease or a condition impacts our help seeking for people who have the disorder. It also impacts treatment outcomes. It impacts our policies, what we allow. Do we do criminalization or do we do treatment? And of course, it impacts where funding goes. It impacts where funding goes for research, where it goes for treatment, where it goes for prevention, and how we deal with the disorder in public. I'm going to go through and tell you about some of the research that my lab we've worked on and people who have been in my lab. And I want to start off, I have to give a shout out to the inspiration of a lot of the work that we've done looking at language and stigma. And it starts with a piece, some work by Kelly and Westerhoff that starts off kind of our story. They did an awesome study. They had about 516 clinicians who were attending 2 mental health conferences. So they're starting off with people who are attending mental health conferences, and they basically stood outside the door of these conferences where there were going to be some talks, some addiction-focused talks. So these are health providers or people, at mental health conferences who are attending addiction-focused talks. And they gave them 2 surveys. And one survey is labeled as a person with a substance abuser. And the other survey is using phrases or using words or vignettes of a person with a substance use disorder. So people got either one of these terms, which were embedded in a vignette describing this individual with substance-related problems. The questionnaire that was distributed with the vignette asked participants to rate the extent to which they agree with various causes associated with this problem. Are they a substance abuser or a person with a substance use disorder? And whether the person should receive more therapeutic or punitive action, if the person was a social threat, and if the person was capable of regulating his or her substance use behavior. The main finding of this is that while there were no differences were detected between groups on the social threat or victimization subscales, there was a considerable difference was detected on the perpetrator punishment scale. Compared to those in the substance use disorder condition, those in the substance abuser condition agreed more with the notion that the character was potentially culpable and that punitive measures should be taken. So let's just think for a second. Even among highly trained mental health professionals, exposure to 2 commonly used terms evokes systematically different judgments of what should happen for this person with a substance use disorder. A former graduate student in my lab, Robert Ashford, and another graduate student at Austin Brown, and I embarked upon a set of multiple studies examining if we could quantify the amount of stigma that words produce. In one of our first studies, we started small. We had about 44 adult participants. We recruited them through online groups who were, basically they were in these groups for people who have a substance use disorder or people who were impacted by a substance use disorder. And we did kind of the old school test. We did the first test, like this kind of the traditional vignette study. Mary is a person with a substance use disorder, and you talk the person through it, very similar to what Kelly did. So we started with a vignette study, and then we also did this what's called a go, no go association task. And basically, we're using certain words where the 2 words we used were substance abuser and a person with a substance use disorder. And what you're doing is you're associating good with that word or bad with that word. And we also did the social distance test. This is a test very common when we were looking at researchers that have looked at kind of racism and discrimination. And it's how much social distance, how much space you want between you and another person. The major finding here is that while both terms elicited negative associations, substance abuser plus bad was the strongest negative association. So this replicates what Kelly had found, but instead of using the vignettes, we were really kind of testing the use of the no-go-no test. Well, we also wanted to quantify other words, so we looked at addict and then person with the substance use disorder in a very similar kind of diagram methodology. And what we found here, to no one's surprise, addict had the strongest, addict plus bad had the strongest negative association. Then we decided in a very large study of around 1,300 people, we wanted to look at various tasks, so various groups of words. We're trying to find, in our list of what are the better words to use. So we did the go-no-go association task, as well as we did the vignette design that we've been using before. But we looked at 7 types of groups. So we have like substance abuser versus person with a substance use disorder, addict, alcoholic versus a person with an alcohol use disorder. We looked at relapse versus reoccurrence of use. We looked again at opiate addict versus person with an opioid use disorder, and medication-assisted treatment versus pharmacotherapy, as well as medication-assisted recovery and long-term recovery. So the main findings is that the terms addict, alcoholic, opiate addict, and substance abusers were the most strongly associated with negativity and significantly different from their positive counterparts. Let's stop using those words. Relapse and reoccurrence of use were strongly associated with negative. However, reoccurrence of use had more positive associations. So we recommend reoccurrence of use over relapse. Pharmacotherapy had the strongest positive association, and so we recommend pharmacotherapy over medication-assisted treatment. One of the things that we recognize is that people there's many recovery paths, and the use of negative labels serve a purpose. Identifying as a person who says, I am an addict, I am an alcoholic, can serve as a mechanism of change and empowerment. And so we wanted to look at how people with a substance use disorder self-identify, and in what areas, and when do you say I'm an addict? When do you say I'm a person in recovery? When do you say I'm a person with a substance use disorder? So we ran a study to look at kind of how people identify themselves and how they label it. We had about 54 participants that we gathered online, and people did use both terms. They labeled themselves as a person with a substance use disorder or a person as an addict, and they did use these terms commonly in mutual aid groups as well as with family and social media. But the main finding is that, one of the other things we did in this study is we wanted to see if you use certain terms, did you have better outcomes? And we didn't find any statistical differences between the labels that people use, as well as like their recovery capital, self-esteem, internalized stigma, shame, and flourishing and length of recovery. One of the things that also our director talks about is that words matter. And given the gravity of the current overdose crisis, it is urgent that we conduct research aimed at overcoming stigma toward people with addiction. Yet even in the absence of research, common sense can guide us. Respect and compassion are essential, and we should refer to people and not as their disorder. I'd like to thank everyone for listening to some of the latest research on language and its kind of nuanced part. I'd like to thank my team. Without my amazing team, we wouldn't be here. I'd like to point out some work that I'm doing with collaborators. We're actually looking at how stigma is processed in the brain using fMRI studies and how it relates to pain. So how it's operationalized like pain. And of course, I have to thank my scientific director and the director of NIDA and point out that all of our research has been funded by NIDA. Thank you.
All right, thank you, thank you. I'd just like to thank all of the speakers. You have presented a phenomenal topic and have done a great job at presenting it. I work closely myself in this field of addiction, so stigma is definitely something that has impeded many patients from working through their recovery process. And if any of you, I'm just going to open it up by saying, is anyone here, how do you feel about the stigma generated by staff and individuals who even treat patients? We assume that everyone who's working with patients don't stigmatize them, but there's definitely a case of stigmatization within the staff. And I believe there is a article out there that addresses that. Any of the panelists here have any comments? And then I'll go to the audience as well.
Yes, some of the research, some of the audiences, and we did like 8 studies, and one of them were people in substance use, mental health providers. And they too, you know, we commonly in substance use treatment, we use words like clean and dirty urine. We refer to people as an addict. You know, it's a very common word or language. And one of the things that we're trying to look at is to see people who have internalized stigma or internalized bias, do they respond more negatively in treatment when they hear that type of language? We're trying to see like how it works. So yes, I mean, it's common in the field.
We do have comments. Someone asked, what's the difference between opiate addiction and OUD?
OUD, a person with an opioid use disorder, elicited less negative association than saying someone was, I don't know, an opiate addict. So yeah.
Yeah. We have Dillard. In my 31 years of diagnosis, I have actually reported staff for externalized stigma. Good for you. Good for you. We have, who is this? Who has commented that Collins does education apparently in this area and has found that educating individuals is helpful, and that they've even used an example of someone liking caffeine and sugar, and used an example of what if you told them that they can no longer use those things. So that's another approach someone has put out here as well. Also, Wanda has, how do we as a society educate cultural humility? Any comments on that? And it looks like everyone enjoyed the video.
Well, I'm not sure about how to teach people humility and civility. One of the things I can't remember which panelist talked about dehumanization and kind of this being discrimination. We're looking in our lab too at how language in the media, people are how people with a substance use disorder are dehumanized, and you know how that's changed over the years, and how it's changed by that person, the drug of choice, or the drugs that they're being referred to. And so I just wanted to give a shout out when I heard someone say dehumanization. I was like, yes, that's what we have. So how do we teach people not to dehumanize? I mean, we're working, some behaviors have become less dehumanized, but we still have a way to go. I can't remember who mentioned dehumanization.
Yeah, I would just add that I think that we need to move towards separating the individual from their behaviors. And that can be really difficult for many of us to do, because we have to remember that it's the behaviors that are truly stigmatizing. And so if we can move away from kind of assigning moral identity related to those behaviors, we're going to make much more movement in this area.
Yeah.
If I could speak on that from the perspective of organizations, I think right now we're really undergoing a big effort to find out about other cultures, other backgrounds, what people's individual stories are. And I know when we were doing our interviews and our research, it was felt like in areas where geographically people haven't been exposed to a diverse audience. They haven't really had the metropolitan rural experience. They haven't. And so some of the comments that are made and some of the things that are said are sometimes out of that place of ignorance and just not being educated. So yeah, Ryan says he grew up in rural Kentucky, he or she.
Yes.
Yeah, so you understand.
Yes, yes.
Yeah, Cheryl, I would add to that too, that, you know, when you look at what's actually the driver in trying to decrease stigma, one of those factors is empathy, right? By increasing empathy. And if you look at some of the research around empathy, one of the things that can help increase empathy is increasing cultural competence. So, you know, focusing on trying to educate people more about other cultures can help, you know, help them get into a situation where they are more likely to empathize with people who are different than them.
And I think it's important, all of you have done a great job at presenting this topic. The videos are great. I'd like to see more of those types of interviews and things. I think that helps individuals see themselves and kind of, you know, relate to more positive reflection on any situation that you guys have presented here in terms of stigma. We all have to be more conscious and aware of interacting with patients and with each other, and maintain that confidentiality in your conversations inside the clinic and outside the clinic. So I really appreciate all the speakers here today. Please forgive me for being a little discombobulated today. I had an emergency, so I was a little off track, but I appreciate your patience and your expertise in presenting this topic to everyone here. So thank you. Did we have any further questions? I think.
There was one question I see by Russell. Can someone speak to the use of the expression drug of choice? It really is not a choice. I haven't researched that phrase drug of choice, but just like the part about the moral failing and the point that people, you know, this is a choice, that itself brings up a lot of stigma, which is part of the reason, like the concept of relapse versus reoccurrence of use and some of the others. And yes, I think we should not use the phrase drug of choice.
Well, you know, that's interesting you said that, because I know a lot of the intake interviews ask that question: what is the drug of choice? And I'm assuming towards a treatment protocol that question is answered. But could there be a different way of putting it? I don't know. You guys are
something that we're all like kind of working here is that we have our research hat on. You have your kind of treatment hat on, and then you have your hat of talking to the general public or talking in journals, which is very different, because like sometimes when you're writing a question or you're talking to someone, you want it to be simple in lay terms so people can respond without having it being all these qualifiers. But sometimes that default language is not necessarily, it may not be the best language, and it definitely probably isn't the language we should use when we're talking to the lay public. So like we've kind of done some work of like, you know, these terms are okay in research, but these terms should not be used in journalism. And so, but it's very complicated.
Yeah.
Also the right for people to self-identify, how if they want to say that they're an addict, they have that right to call themselves an addict.
And I think if we treat it or speak to it in terms of approaching it as what's best for you. So the more information I have about your condition, the better we can treat you. So maybe if we come from a standpoint of what's your, you know, drug of choice, start with, so that we can best treat you, we need to know a little more history about what substances you have abused, you know.
Or just saying, not abuse, but or what substances you've used, not abused.
Yeah, and see how it just flies out of your mouth.
I have a hard time when you're talking about like alcohol, you're like heavy use, like it just gets really sometimes complicated. I get it.
Yes.
I'm not trying to be the language police.
No, no, we appreciate the sensitivity to the topic. So again, I want to thank all the speakers. I don't know in terms of our time, but I think that we have addressed most of the audience's questions, comments, and closing yeah, I'm looking at a few other things. It's very similar. I think also that, oh, thank you. So we have some time. But I think that, I think it would be good if maybe,
What didn't Andrea, didn't you guys have more that we kind of cut you short because we were afraid
Yeah.
of time?
exactly.
So
Would you-
we had the discussion planned within our talk. So at each, like 3 times, we had intended to take a little break and kind of get people's comments and ideas and seeing if they have experienced that themselves or witnessed, and then also ideas on how to go forward and incorporate this in education, because it is so important to educate our medical students, our residents, our physicians, all of them, but also our patients. And Penn State is one of the first hospitals that has a non-discrimination policy from patients to providers. So there is a patient bill of rights, but there is also a patient bill of responsibility. So the patient cannot discriminate, is not allowed to discriminate against the provider that is going to see them. And that is, of course, important in a rural setting where the doctors might be international or from bigger cities, minoritized providers, but also it is very important in all settings across the country.
I think your point is taken. We have to look at also the environment in which individuals tend to operate within, and when they go outside of that environment, there's a level of discomfort that may be expressed, not necessarily, in the best way, but in terms of their comfort with who they prefer to be treated by. So as the gentleman suggested, where his upbringing is, may suggest, his early comfort zones. It doesn't mean that people don't mature and become more diverse, but at the same time, a lot of times interactions come out of that, if I'm not mistaken.
Yes, but that cannot be an excuse. And as Dr. Kainak said, empathy is the key feature here. And that can be expected of everybody.
Yes, that sounds good with the what expectations, not only for the patient, but also for the patient and their interactions with the staff. So
I think some of it is also educating the next generation. We had a really interesting little story in our research where a African-American female physician was in a clinic checking up a patient. Correct me on this, any of these details, Dr. Andrea, if I'm wrong. Seeing a patient, got done, working up, I guess it was the mom, and the little child said, "When is the doctor coming in?" And looked at her, and the child was of color also. So the child looked at her and said, "When is the doctor coming in?" And she said, "I am the doctor." And the child said, "No, you can't be a doctor. You're not white." So it's, these little early narratives get hardwired into our brain. And then it's very awkward. Like in that interview, story that we got, how do you rectify a situation like that? The parents were horrified. But yeah, so it's so subtle and so covert sometimes.
yeah, amazing. Those video vignettes were very, very good.
It looks like there's a question in the Q&A about changing recovery space consciousness to adapt destigmatizing language. And I'm sure Brenda can talk a lot about this as well, but I think part of changing the language in recovery spaces is, again, kind of educating and getting the research out there that shows just how damaging a lot of this language can be, and how many individuals do internalize those labels. And that internalization then can impact how well they do in a recovery space. So, you know, I think mental health field, and Dr. Volkoff has written about this, but, you know, they've done a lot better than we have in the addiction field in getting that message out there, that it's okay to talk about it. And, you know, it's really, you know, it's something that a lot of, and I notice it in my students, especially, that, you know, throughout the time from when I started teaching undergraduates to now, they're much more open about their mental health, needing help, reaching out, you know, saying they need to get treatment or whatever. But you don't see the same thing when it comes to substance use. So I think, you know, in the addiction space, we need to get better about keeping the conversation going and encouraging people to really talk about, you know, their experience and their story, and really normalize addiction.
And what about the advocacy in this field? I noticed that we too ourselves here at our program, that there's a growing population of the peer specialists and peer coaches. I think it's, I've walked in your shoes, so I understand your perspectives. I think has made a difference as well in terms of the total treatment program and adding peers to the staff. We have them now in our ER as well as in the clinic, and they help in terms of approaching and interacting with patients and the environment. They also make the patient as just as responsible for the environment and their treatment as the staff, you know,